Hi, this is Dr. Joshua Cooper, and in this video I'm going to teach you all about the treatment of atrial fibrillation. I have found that the easiest way to think about treating A.Fib is to break it down into three main steps. And at the end of this video, hopefully you'll understand the strategies of how we minimize the risks of atrial fibrillation from a medical perspective, and also improve symptoms from a quality of life perspective. Let's start by understanding what atrial fibrillation is in the first place. When the heart is in its normal pattern, called sinus rhythm, the normal heartbeat, the top and bottom halves of the heart beat one at a time. Top, bottom, top, bottom. That's how the heart is most efficient. And each heartbeat normally, in normal rhythm, starts in the top right part of the heart in the natural pacemaker spot, also called the sinus node. This is, of course, the person facing us. So this natural pacemaker spot is in the top right part of the heart, and it sets the pace. It beats slower when the person is at rest or asleep, and it speeds up in response to adrenaline when we're up and about doing physical activity. And every time that top part of the heart fires electrically and makes the top part squeeze first, the signal then travels down a special electrical bridge, which we'll talk about more later. And that electrical bridge allows the signal to get down to the bottom pumping chambers of the heart, so the top and bottom halves can cooperate one after the other efficiently. In contrast, atrial fibrillation is a very rapid chaos in the top part of the heart where they're squeezing in such an irregular pattern, almost like they're having a seizure, and that makes the bottom pumping chambers beat in an irregular pattern, often very fast, and that can create symptoms of palpitations in the chest. It is the bottom chambers that create the pulse. They're the ventricles, and that's what people feel when they're feeling a sensation in the chest. It's the bottom half of the heart. And what causes atrial fibrillation to happen is little trigger spots, little electrical signals away from the natural pacemaker spot that can start firing quickly and throw the top chambers into this chaotic atrial fibrillation pattern. In addition, scar tissue can form in various places in the top chamber, and that can lead to little short circuits happening, which can prolong episodes of atrial fibrillation. Trigger spots in scar tissue tend to build up over the course of our lives, so as we get older, they're more commonly occurring, and that's why atrial fibrillation gets more common as we get older, and we're going to talk a little bit more about that as well. So I mentioned that there are three steps in treating atrial fibrillation, so let's review what these steps are right now. The first step is to reduce the risk of stroke. People with atrial fibrillation are at an increased risk of stroke, and we will review why, and that is the most important first step when we have somebody with atrial fibrillation. The second step is to try to prevent the heartbeat, the bottom ventricles, the pumping chambers, from going too fast during atrial fibrillation, and we'll review methods on how we can do that. And the third step of treatment is to try to keep the heart in normal rhythm. For every single patient, we're going to do those first two steps. We're going to reduce the risk of stroke, and we're going to control the heartbeat from going too fast. And in many people, but not everybody, we're going to take additional steps to try to keep the heart in normal rhythm, but that's not an essential component of atrial fibrillation treatment, and there are some people where we may not do that third step. So let's start out with step number one of A.Fib treatment, which is to reduce the risk of a stroke. If you take blood and let it sit still, for example, pour it into a cup and let it sit there, then clots are going to start forming. There are cells and proteins in the blood that are going to stick together and solidify that blood and form clots. If you were to stir it around or shake it around, that will delay that process and delay the formation of blood clots. Well, when the heart is in atrial fibrillation and those top chambers are quivering, they're not squeezing the blood and pumping it and pushing it forward and stirring it up normally. And so the blood is sitting around in those top chambers more than normal, especially in the little nooks and crannies, because they're not really smooth the way I have drawn it here. And in particular, there's one little pouch called the left atrial appendage in the top left part of the heart, where blood is most commonly sitting around, not moving very much, and that is by far the most common place where blood clots can form, in this left atrial appendage, this little pouch in the top left part of the heart. And if a little piece of a clot were to break off and get pumped out of the heart and go up and get stuck in one of the arteries, one of the blood vessels in the brain, that's how a stroke happens. And sometimes the blood clot can completely break free and break up into lots of pieces, and all those pieces can go up into different places and cause strokes in multiple locations all at once. This is what we're trying to avoid in patients with atrial fibrillation, and that's why step 1 is so important. Here is an ultrasound of somebody who is in atrial fibrillation, showing a part of the top left chamber of the heart, the left atrium. And you can see there a blood clot that is sitting in the left atrial appendage. This little outpocketing here is the left atrial appendage, and this is a blood clot that has formed in this person with atrial fibrillation. When blood moves quickly, it looks black. It doesn't show up on ultrasound very well. But when blood is flowing very slowly, then it shows up as sort of gray swirls. It almost looks like smoke. And in fact, we do call this smoke when we're doing an ultrasound of the heart and we see sluggish blood flow. And that is blood that is more prone to forming blood clot. So how do we reduce the chance of clot forming and causing stroke? The main way and the best option we have is to put the person on a blood thinner medication, a medicine that can reduce the way that the proteins of the blood can stick together and form clot in areas of slow blood flow. And there are a number of medicines in this category that are used. I show you here the generic and the trade names of each of these most common medicines, and I'm sure there will be more that will be developed over time. Warfarin, the one at the bottom, is the oldest one and the cheapest one, but it can be very complicated to use because it has many drug interactions, it interacts with certain foods, and the blood has to be tested regularly in order to get the dose just right, and the dose often has to change. The top 3 are much easier to take because there aren't blood tests that are needed, they have many fewer interactions, and they're much more predictable in how they thin the blood. And all of these medicines work to try to prevent blood clots from forming in the first place. They don't actually dissolve clots, but they prevent blood clots from forming in the first place. So if somebody were to have a blood clot in the heart because they're found to have atrial fibrillation and they get put on a blood thinner, then the blood clot will gradually dissolve through the body's normal mechanism over time, usually a few weeks, and these medicines will prevent more blood clot from forming. Sometimes people can't safely take a blood thinner in the long run, and there's another option that we can use, taking advantage of the fact that most blood clots, when they form in this one specific place, this left atrial appendage. And there are different ways of closing off that appendage. One way is when a surgeon is going into the chest to do a heart surgery because of blocked arteries or a valve problem or both. Sometimes the surgeon can close up that appendage by either sewing it shut or putting a little special clip over that device. It's not perfect because sometimes that clip can miss a little bit and there can be a little pouch outside the clip, or sometimes this outpocketing is complicated and the clip is put on most of it but it misses a little part of it. So it's not perfect, but it is one technique that is sometimes used by a surgeon to close off that appendage. Another more common method is to not have heart surgery, but use a catheter technique, meaning insert a long tube through the vein in the top of the thigh, thread the tube up inside the heart, and you can use a little device that collapses inside the tube. You position it near the opening of this appendage, you push it out, and it pops open kind of like an umbrella, although without the handle. And there are little hooks that can hook this device in place, or there's different ways that it can sit right at that opening, and it can therefore block the appendage. It's also not perfect. It's now a foreign surface that you have inside the heart. Over time, it takes weeks or months or sometimes a little bit longer in rare cases where a new lining can grow over the surface and then can hide that foreign surface from the bloodstream and prevent clots from forming on that little device. But this is another technique that is sometimes used in patients who cannot safely take a blood thinner. In the long run, we can block off this appendage instead. But the best option overall, if someone's able to do it, is to take a blood thinner pill. That's our best weapon against clot and against stroke in atrial fibrillation. Let's move on to the second step, which is to try to keep the heartbeat from going too fast during atrial fibrillation. The heartbeat, as I mentioned, is determined by what the bottom chambers are doing in atrial fibrillation, and in different people they can go at different speeds before medicines are started. Here's an example of somebody who's in atrial fibrillation where the top part of the heart is beating very fast and irregular, and the bottom pumping chambers are irregular but beating slowly. This person has a pulse of 45 beats per minute. Here's another person who's also in the same atrial fibrillation, but their bottom chambers are beating much faster at 130 beats per minute, also in an irregular pattern. Well, what's the difference between these two people who may not be on any medications? In both cases, the top part of the heart is in atrial fibrillation and it's shivering in that seizure-like pattern going really fast. But as I said, on the left, the person's bottom chambers are going slow, and on the right, they're going fast. So what is the difference between those two people? The difference has everything to do with that special electrical bridge that connects the top to the bottom half of the heart, which I mentioned at the beginning of the video. All of us have an electrical barrier that separates the top half from the bottom half of the heart electrically. Signals can't just get across anywhere from top to bottom. So when the heart is in atrial fibrillation and the top half is beating at 400 or 500 times a minute, those signals are trying to get down to the bottom, bombarding that connection between top and bottom. But the only way that signals can get through is over that special electrical bridge, which I mentioned before. And every time a signal gets across the bridge, it makes the bottom chambers beat once. So that electrical bridge is different from one person to another. In some people, that bridge allows a lot of the A.Fib signals through. And in another person, that bridge may be slow. As we get older, that bridge does tend to slow down, but it's not exactly predictable, and so it's not only related to age. But in most people, that bridge is fast enough to let enough signals through that when someone goes into atrial fibrillation, their pulse is easily over 100 and sometimes up close to 200 beats per minute in the bottom chambers. And that can result in differences from one person to another depending on how their bridge works. That bridge is called the AV node. That is the medical term for this connection. And if the bottom chambers are pumping too fast, the problems that can happen are, number one, that person can feel worse symptoms. Most people, when their pulse in the bottom goes faster, they feel more of those heartbeats and they feel worse in terms of lightheadedness and palpitations and shortness of breath. But in addition, if the bottom chambers beat too fast for too long, going well over 100 beats per minute for week after week after month, some people can have a weakening of the bottom chambers of the heart. These are reasons that we need to control that bridge and how many signals are getting across. So how do we accomplish this step number 2 in the treatment of atrial fibrillation, keeping the pulse slow? If somebody's bridge allows signals to travel quickly during atrial fibrillation from top to bottom, then the strategy has to be to slow down that bridge. And the best option we have, option number 1, is to use medications that slow down that bridge. They're often referred to as AV node blockers, although blocking is not what we're doing. We're really slowing it, so I like to call these bridge slowing medicines. So what these medicines have in common is to change the properties of that electrical bridge and slow it down so that signals are more sluggish getting across the bridge. And there are different categories of medicines that can accomplish this. One category is called beta blockers. These are metoprolol, carvedilol, atenolol, or other medicines that end in olol. Those are called beta blockers, and they can have a bridge slowing effect. There are a couple medicines in the category called calcium channel blockers, diltiazem and verapamil, and each of these have trade names as well. And then the third medicine is called digitalis or digoxin, and sometimes we use a combination of more than one of these medicines, which combined can have even a greater slowing effect on that electrical bridge and thereby slow down the pulse. Sometimes these medicines don't work, and we'll talk about this more later in the video, but there's a second option which we sort of think of as sort of a last resort, which is if medicines are not working for one reason or another, we can actually burn that bridge and permanently damage it. This is called an AV node ablation. And this is sort of a last resort that's rarely needed. And again, I'll review this later in the video. I wanted to show you examples of EKGs of people in atrial fibrillation to show you how your doctor knows that you're having atrial fibrillation and whether your pulse is fast or slow. Here's somebody in atrial fibrillation with a fast pulse rate averaging about 139 beats per minute. Each of these spiky things is the bottom part of the heart, the ventricles firing, and you can see they're going fast and irregular with some slower and faster beats side by side. Here's another person also in atrial fibrillation with a much slower pulse. This person's electrical bridge may be going slower on its own, or this person may have been put on a bridge slowing medication that slowed down how many signals are getting from top to bottom. You can see here that the little spiky things are farther apart. That is because the pulse in this person is much slower, averaging about 62 beats per minute. Now, some people will say, I used the little thing on my finger, the pulse oximeter, and it showed me that my pulse was normal in the 60s, therefore I must not be in atrial fibrillation. That's not exactly true, because we reviewed that somebody could be in A.Fib with a faster or slower pulse, depending on how their bridge works or what medicines we have put them on, and simply seeing what the heart rate is doing doesn't always tell you that you're in atrial fibrillation or in normal rhythm. Here, for example, is somebody who also has a pulse of 62 who's in normal rhythm or sinus rhythm. And the difference becomes clear when you compare the EKGs. The person who's in A.Fib with a pulse of 62 has varying heart rates one beat to the next, and we call this irregular because the pulse rate is irregular, whereas somebody who is in normal rhythm with the same absolute heart rate is regular. The distance between the spiky things is the same. And so it isn't simply a matter of what is the pulse rate that can tell you if somebody's in A.Fib or not, but it is the pattern of the heartbeat as well. So if you're feeling your pulse or you're using a device, whether it's a smartphone app or a watch, those devices will often look not just at the heart rate, but also how regular or irregular the pattern is. And if they have programs that can diagnose atrial fibrillation, it's usually based on that irregularity, where it will report that you're in A.Fib or not. Now, you can also have early extra beats, and if they come frequently enough, even if you're in normal rhythm, it can fool these types of devices into thinking that you're having atrial fibrillation, so it may report out possible A.Fib or something of that sort, but an EKG can always tell your doctor what rhythm you're in. Many patients who have atrial fibrillation will go in and out of atrial fibrillation on their own. We call this paroxysmal atrial fibrillation, and that means they're able to pop in and out of A.Fib and go back to normal rhythm on their own. Here's an example of such a patient where this heart monitor strip shows on the left that they're in A.Fib with an irregular rapid pulse around 114 beats per minute, and then they on their own pop back to normal rhythm where they have a regular pulse at 63 beats per minute. And if this person feels palpitations or shortness of breath or other symptoms related to their fast A.Fib, we may add or increase their bridge slowing medicine to control the pulse and bring it well below 100 beats per minute when they are at rest to control symptoms, and also reduce the risk of a fast heartbeat if it happens too much from causing weakening of the bottom chambers of the heart. Here's another person who's going in and out of A.Fib with a slightly different situation. On the left, they're going fast and irregular with a pulse around 120 beats per minute. But this person, when they pop back to normal rhythm, is going much too slow with a regular pulse that's 28 beats per minute. And this is because at this moment in time, their natural pacemaker spot, that sinus node, is beating much too slowly, either because their sinus node simply doesn't work well, which can be a problem as we get older, or because they may be on medicines that can slow that sinus node, or sometimes when somebody's in A.Fib, that has a suppressing effect, a quieting effect on the sinus node, and it may take seconds or minutes for the sinus node to kind of wake back up and function properly. And when this person goes from A.Fib back to normal rhythm, they may suddenly get lightheaded or even faint during that switch from A.Fib back to normal rhythm. And if this person feels symptoms in their A.Fib, we actually cannot safely increase their bridge slowing medicine to better control the A.Fib. And the reason is that the medicines that we use to slow down that bridge also have a slowing effect on that natural pacemaker spot, that sinus node 2. So this is a difficult situation to be in. You're sort of stuck between a rock and a hard place, where on the one hand you may want to add or increase medicine to slow down the A.Fib, but on the other hand you want to take away those medicines when they're in normal rhythm to allow it to speed back up. There's a medical term for this situation called tachybrady syndrome. Tachy stands for tachycardia, meaning when they're in A.Fib they go fast. Tachycardia means fast heartbeat. And Brady stands for bradycardia, slow heartbeat when they're in normal rhythm. And this can be a difficult situation to manage with medicines alone. And one of the most common ways that we tackle this problem is by putting in a pacemaker. A pacemaker is an electrical device, and there are different kinds of pacemakers. And the purpose of a pacemaker is to treat and prevent a slow heartbeat from happening. So in this person, if we put in a pacemaker, then we can set it at 60 or 70 or 50 or whatever rate we choose, and it will prevent the heart from ever going below that rate. So when they're in their normal rhythm, the pacemaker will kick in and keep the heart beating steadily. And then we can add whatever medicines we want to treat the atrial fibrillation and not worry anymore about a slow heartbeat when they're not in atrial fibrillation. It's a perfect balance between pacemaker and medicines. Many people ask, by the way, does a pacemaker treat A.Fib? And the answer is no. However, many patients with A.Fib may need a pacemaker because the other treatments for their A.Fib may result in too slow a heartbeat at times, and a pacemaker will allow us a lot more liberty to use treatments, including medicines, to treat the A.Fib and no longer worry about a slow heartbeat. If you want to learn more about pacemakers, I have a separate video that gets into much more detail about how pacemakers work and living life with a pacemaker and different types of pacemakers, so I refer you to that video if you want more detail about pacemakers. So to summarize, we've now talked about the first two of the three steps of treating atrial fibrillation. The first step is to reduce the risk of blood clot and stroke. And the second step is to prevent the heart from going too fast for too long when the person's in atrial fibrillation. And so, if you have a new diagnosis of A.Fib, the first two things that your doctor will do will be, number one, to start you on a blood thinner medication. That's step one, to reduce the risk of stroke. And they will start you on a bridge slowing medicine if your pulse goes fast during atrial fibrillation. That's step two. So let's move on to step number three, which is trying to keep the heart in normal rhythm, which we don't do in everybody, but we talk about and we consider it in many patients with atrial fibrillation. In order to best understand how the treatment options for atrial fibrillation work, we need to understand in a little more detail why A.Fib episodes happen. I mentioned at the beginning of the video that there are firing spots and areas of scarring that form in the top part of the heart and are responsible for starting up an episode of A.Fib and causing it to continue. Here is an amazing picture of the back wall of the top left part of the heart, the left atrium. This is from Dr. Suyan Ho, and she's a well-known heart anatomy specialist. And the reason that this picture is so terrific is that it shows the muscle fibers of the left atrium on the back wall, and it shows the veins, they're cut here, that bring blood from the left lung filled with oxygen into the left atrium, back into the heart, and from the right lung through these veins into the heart. These are the left pulmonary veins and the right pulmonary veins. And the reason that this anatomy is so important is because the trigger spots that start up episodes of atrial fibrillation are very predictably located in the area where these veins enter the left atrium. This is a hot spot for A.Fib triggers. Why do these triggers show up? The most common reason is simply getting older. As the heart ages, as we get older, these trigger spots tend to show up and scarring tends to form. And so as we get older, A.Fib becomes more common. But there are also some medical conditions and other situations that can play a role in triggering A.Fib or making it more likely to happen. One of the most common ones is sleep apnea. So when people have A.Fib that happens mostly or only at night and they wake up with A.Fib in the middle of the night or in the morning, we may refer that person for a sleep study to see if they're having sleep apnea. A whole variety of other situations and medical conditions can also increase the risks of A.Fib, including being overweight, high blood pressure, diabetes, other heart problems, including valve problems. Sometimes other medical conditions like a thyroid problem can increase the risk of A.Fib. Drinking alcohol can be a trigger for A.Fib in many people. Having surgery, such as heart and lung surgery in particular, can temporarily increase the risk of A.Fib for a few weeks after that surgery. Having respiratory infections and pneumonia or other airway infections can also be a trigger of A.Fib. But by far, most commonly, we don't know any obvious reason why somebody has A.Fib. It seems to be somewhat random other than related to age, and we don't always have an explanation. I mentioned before the scarring, and in addition to the trigger spots being located in the areas where the pulmonary veins enter the left atrium, areas of scarring also tend to occur in very similar locations, and these can contribute to short circuits that can cause episodes of atrial fibrillation to last longer. Here's the start of an A.Fib episode. I showed before an A.Fib episode popping out back to normal rhythm, and here's the opposite, a person who's going into an episode of A.Fib. And just to understand the mechanism of what's going on in the heart, I want to use little icons to show normal heartbeats, trigger spots firing once or multiple times, and little short circuits, just to show you the sequence of things that tend to happen when somebody goes into an episode of A.Fib. They start in normal rhythm, and here are normal heartbeats. There's one trigger spot, another beat, and then a whole bunch of trigger spots and short circuits that start going. And here is how an episode of A.Fib starts. And this is what we think about when we're coming up with methods to try to suppress atrial fibrillation with medicines or procedures. I mentioned that there are different patterns of A.Fib, and we can use heart monitors that are worn for a week or 2 or 3 or 4 to watch a person's pattern of atrial fibrillation, and that gives us some clues into the best methods of how to treat each individual person. So here's a person who is wearing a heart monitor who has atrial fibrillation, and what we're seeing here in the bar graph is day by day what is going on with that person's heart rhythm. Atrial fibrillation is shown here with black bars, and this person had atrial fibrillation on 3 days of this week, Tuesday, Wednesday, and Sunday. And you can see here the amount of A.Fib that they had on each of those days. And in total, this person had an average of 18% atrial fibrillation over time, going in and out of atrial fibrillation. And this person has a pattern that's called paroxysmal A.Fib. That means they go in and out of it on their own. Here's a second patient who's wearing a heart monitor who has A.Fib. And this person has atrial fibrillation all of the time. You can see only black bars every single day of the week, and this person is in 100% atrial fibrillation. And we call this pattern persistent. That means that when they go into A.Fib, they just stay in it long-term on their own, and their heart doesn't have the ability to pop back to normal rhythm by itself. In patients with persistent atrial fibrillation, we may refer that patient for a procedure called an electrical cardioversion. What does that mean? It's a very simple procedure that gets a person who's staying in A.Fib to get back to normal rhythm. Again, here's that person having their trigger spots and maybe their short circuits causing A.Fib to continue happening. A cardioversion is a procedure where we put in an IV, we give the person anesthesia to put them asleep for just a few minutes, and before we do that, we put sticky patches on the front and back of their chest, sandwiching the heart in between them, and we connect those sticky patches to an external defibrillator. This is the same type of device that can be used to rescue a patient in a life-threatening rhythm, but it can also be used for a non-life-threatening rhythm for atrial fibrillation to deliver a controlled shock under anesthesia to kickstart the heart electrically back to normal rhythm. So we connect the device, we put the person to sleep, and then we push a little button when they're asleep to deliver an electrical shock, a jolt, to kickstart the heart back to normal rhythm. Again, it's called an electrical cardioversion, and it works very, very well to restore a normal rhythm. But what it does not do is prevent the next episode from happening. Another episode of A.Fib could start seconds later, minutes later, days, weeks, or months later. So this is sort of an electrical reset, but it does not have any lasting effects to prevent future episodes of atrial fibrillation from happening. So how do we prevent future A.Fib episodes from happening? And here again, we're going to go back and think about these trigger spots that are firing away, starting each episode when it should occur. And there are medication options and there are procedure options. And let's review how each of these works. The purpose of medications is to quiet down these trigger spots. And if we had some type of repellent, A.Fib repellent, where we could just spray it on those triggers and get them to quiet down, that would be a method of preventing A.Fib from happening. Well, we don't quite have a spray, but we have pills. We have medications called antiarrhythmic medicines. And what these do is quiet down these trigger spots from firing. And by suppressing these spots, we can hopefully prevent future episodes from happening. There's a whole variety of medicines in this category, and I have them listed here. And there are pros and cons of each. There are some that we don't use in certain types of heart conditions. There are certain ones that are eliminated by the kidney, so people with kidney problems can't take them. There are some medicines that we can only start in a monitored setting in the hospital. And that last one, amiodarone, is a medicine that works very well, but if it is taken for years, it can have some other side effects and toxicities that we have to watch out for. So there are pros and cons of each of these antiarrhythmics. But again, these of course are pills, not a spray. And in order for them to keep working, you have to keep taking them. You can't just take a pill once and quiet them down and then stop taking the medicine, because the medicine wears off. So in order for a medication approach to work, you have to continue to take it long term to suppress the A.Fib triggers. The other method of preventing A.Fib events from happening is a procedure option. And here we don't aim to quiet the triggers, but instead we try to permanently eliminate the triggers. And so we again take advantage of our anatomy knowledge, and we know where these trigger spots tend to live. And we can do a procedure where we go up inside the heart and we do a procedure to try to eliminate permanently these trigger spots from being able to cause A.Fib from happening. We call this an A.Fib ablation procedure. Ablation means to permanently damage heart muscle. And because there are usually multiple trigger spots, the most common strategy we use to eliminate the triggers is to trap them in regions. We place a series of burns around the region where these A.Fib triggers are clustered to try to prevent them from electrically communicating with the rest of the heart. Sometimes there are other triggers located outside the area of where those pulmonary veins are, and we can find them and go after them separately by zapping those triggers separately and individually. And whether we trap the triggers or zap the triggers, that is the main strategy for an A.Fib ablation. And we also will often look for areas of scarring, and sometimes we'll do ablation in other areas too, on the back wall of the left atrium or in other places where we find scarring that we think may be contributing to atrial fibrillation. And of course, we don't use a laser pointer in order to do this. We have long, thin wires called catheters that we thread up from the vein in the groin up inside the heart. And we use this ablation catheter to do this A.Fib ablation procedure, tailoring our approach to the individual patient, but usually focusing on that area on the back wall of the left atrium where the pulmonary veins enter the heart. What are the pros and cons of medications versus an ablation procedure? Because there are advantages and disadvantages, and we consider these in each individual situation. With medications, there's obviously no procedure risk if you don't do a procedure, so that's an advantage. But there can be side effects of medications. There can be interactions with other medications that the person is taking. Some of these medicines, as I mentioned before, require monitoring in a hospital setting, usually for 3 days. So in order to start up a couple of these medicines, we bring the person into the hospital in order to monitor them and make sure we get the dose just right and make sure they're not one of those people that can't tolerate these medicines, which can occasionally cause other problems such as other arrhythmias. There's a monthly cost because you have to continue taking medications on an ongoing basis for it to continue to work. And sometimes there's some trial and error as we figure out what is the right dose or the right medicine. And if A.Fib is coming back, sometimes we change the dose or change the medicine. So sometimes there are changes needed before we get it right. With regard to a procedure, there are indeed very small procedure and anesthesia related risks that we have to think about when we're recommending a procedure. All of the studies that compare procedure approach, ablation, to medications show that the procedure is more effective at suppressing and eliminating A.Fib compared to medication. So that's a big advantage to an ablation procedure approach. Typically, you go home the same day. Sometimes we monitor people overnight in the hospital if needed, but a lot of the times people who have an A.Fib ablation don't even have to stay overnight. It's an outpatient same-day procedure. There's usually a co-payment in terms of a monetary expense of medicines versus a procedure, but it's a one-time thing. Although sometimes this procedure is not 100% perfect, it's not 100% successful. So sometimes people may, weeks, months, or years later, may need an additional procedure in order to achieve our goals of trying to suppress A.Fib completely or as much as possible. So that's a small downside of a procedure approach, but the same with medications where sometimes we need to make adjustments to the medications. Let's quickly review how an ablation procedure is done. The person will come to the hospital, usually the morning of the procedure. You'll meet the team, you'll see your doctor, you'll meet the anesthesia team and the nurses who will be in the room. They'll get you into a hospital gown and put in an IV that's used to administer the anesthesia medications. They'll bring you into the procedure room. You'll be put to sleep under anesthesia, and they will sterilely prepare the skin in the top of the thigh, the area where we put our IVs through which we will work, and they use a sterile, clean surgical drape on top to keep everything clean and sterile. We put those IVs into the vein at the top of the thigh on each side in the groin area. And we will thread our equipment through those IVs up through the veins and up inside the heart in order to take electrical recordings, use an ultrasound wire up inside the heart to see what we're doing from inside the heart using ultrasound, and we thread our little tools up in order to perform the ablation procedure inside the heart itself. When we thread the wires up into the heart, they end up naturally in the top right part of the heart, the right atrium. So in order to get over to the area of interest in the top left, we make a tiny little puncture in the wall, in the membrane that separates the top two chambers. That's a very safe and easy procedure to do, and that heals up over a few weeks. That little puncture completely closes. We are then, with our tools, able to make a very detailed three-dimensional cartoon picture or map of the inside of the left atrium of that part of the heart, and that gives us a lot of information about the anatomy and the electrical properties of the inside of the heart. It shows us where the pulmonary veins are, and I'm going to show you pictures of each of these steps, by the way, in the upcoming slides. We then can perform ablation, targeting the trigger spots in the areas of scarring in the top left chamber, tailoring the ablation pattern to that specific patient. And when we're done, the wires and tools are pulled out of the IVs are removed, we hold pressure on the veins to minimize any bleeding, we bring the person to recovery, allow them to fully wake up from anesthesia, and in order to prevent any oozing or bleeding from the puncture sites, we have them lay in bed rest for a few hours typically, and then we typically send the person home later that day with somebody else providing a ride because you would have been under anesthesia. Occasionally, if there's any reason, we keep people overnight and observe them and let them go typically the next day, but again, most of the time people go home the same day. Here's an ultrasound that's taken from inside the heart, showing that puncture in that membrane, that wall that separates the top right from the top left chamber. There are different tools that doctors may use in order to accomplish this, but the risk of causing any problems such as bleeding or damaging the heart in a way that we didn't intend is really small, significantly less than 1%, because of the great way that ultrasound can take pictures as we do this, and the specific tools that we have to make this very controlled puncture that, as I said, will heal over time. Ultrasound also allows us to see what's going on in the heart as we perform ablation. And here is a picture of the ablation wire in the heart. It's actually, in this particular case, just sitting between that left atrial appendage pocket, and the pulmonary vein is going down in this direction. And this will be moved from place to place, and we can watch where that ablation catheter is located, and we can make sure that it's in good contact with the inside of the heart wall before we place each of our ablation little burns or lesions in order to start doing the ablation for atrial fibrillation. Here's that picture again of the anatomy of the left atrium, and let me show you the type of colorful map that we can create so that we can see exactly what we're doing. Here is that three-dimensional electrical map that we can create over just a few minutes, and it shows us the anatomy. We can see the left pulmonary veins here and the right pulmonary veins here. Again, we're looking at the back wall of the left atrium with this cartoon map. And we can see where there are areas of healthy signal that are shown here in purple, and we can see areas of scarring or other abnormal areas that are in other colors, with red being the lowest electrical signals. As we go from the heart out into the veins, there's no more heart muscle and there's no electrical signal, so it's normal to see red out each of these veins where there's no more heart muscle, but the red that we can see inside the heart may help guide our ablation strategy. And we can keep track of where we place our ablations in three-dimensional space to within a millimeter precision by seeing little icons that remind us where we have already performed ablation. And we can manipulate this map in all sorts of ways to help us during the procedure. We can eliminate the colors to help see the ablations better. We can make the map see-through to see where we did the ablation as well. And there's all sorts of things that we do to kind of help the doctor through the procedure perform the ablation in a safe and efficient way. We can get really fancy when we're looking at other arrhythmias. Sometimes people don't only have atrial fibrillation, but they can have other rhythms, something called atypical atrial flutter, a different type of short circuit that we also can target when we're in the heart. Here is one of the typical images that we will use while we're doing our ablation and taking pictures inside the heart. Here's that ultrasound picture. Here is that area showing healthy purple areas and scarred red and other areas. And on the right here, we're seeing a fancy way of showing electrical signals sweeping across the heart. And when we see when somebody's in an abnormal rhythm, the pattern of electrical signals traveling through the heart, it can help us figure out the best way to place ablation lesions to try to prevent these rhythms from happening in the future. There are different ways to permanently damage heart muscle and perform catheter ablation for atrial fibrillation, and different doctors may have a preference of one type or another. They're all very similar, and there are very minor pros and cons of each. The most common historic method of doing ablation for A.Fib is called radiofrequency ablation, or RF. This involves placing a little wire up inside the heart and in each place applying energy in a gradual way to heat up the heart muscle and basically make a very controlled burn in a specific place. And you can create a pattern of burns in any way you want to either target specific locations or encircle and enclose a certain area like I showed before around the pulmonary veins by doing a point-by-point type of ablation. Another method is called cryoablation. That means to freeze heart muscle. It's a different way to permanently damage the heart muscle itself and quiet down A.Fib triggers and scarred areas. The best way to accomplish this is to use a balloon type catheter that's inflated. It's pushed up against the opening of where a pulmonary vein enters the heart, and the space within the balloon is frozen with a gas that expands and freezes the heart muscle in a whole circle around the pulmonary vein. And this can be a very quick and efficient way to damage heart muscle when you're targeting the area around the pulmonary veins. A more recent method of ablation is called pulsed field ablation, or PFA, and it sort of acts like a taser. You deliver a series of high energy rapid shocks basically to the heart muscle, and it's yet a third way to permanently damage heart muscle. And again, each of these permanently damages heart muscle in a different way, and there are very minor pros and cons of each, and you can talk to your doctor about what method they prefer to use in your situation. I think it is always important to think ahead. What if nothing is working? What if all of the things I just mentioned to manage A.Fib are not working well? What's left? What kind of problems can we run into? Well, sometimes the medicines that we use to slow down that bridge simply don't work. Either we keep adding medicines and increasing the dose, and the pulse rate during A.Fib is still too fast. These medicines are just not working for a particular person. Or we're adding medicines and there are side effects that just simply are not tolerated. Or the medicines that we're using to slow the bridge have too much of an effect on the blood pressure, and the blood pressure gets too low, which is limiting our ability to use those medications. Or when we're treating A.Fib, what if it's still continuing to happen if we're trying step number 3 to control the A.Fib, because we've tried doing cardioversions, and we've tried antiarrhythmic medicines, and we've tried catheter ablation, and none of these methods are working to keep the heart in normal rhythm? What's left if we're running into problems with our strategies to manage A.Fib? Well, there's something that I referred to before called AV node ablation. And this is a technique that's very easy and very effective, and we sort of use it as a last resort, and it can be very, very helpful in people where the other methods of managing A.Fib simply haven't worked well. This involves targeting the AV node bridge itself with ablation. We can go in with an ablation catheter and just burn the bridge. Forget about the A.Fib in the top part of the heart, but let's go to that bridge and burn it. It's very easy for us to do this. It's over 99% effective. It's very easy. It's very quick. It's very safe, and it's permanent. But what is the downside of burning the bridge? When we burn the bridge, no signals can get from top to bottom at all, which is wonderful in terms of preventing a fast or irregular pulse. But the downside is now nothing is telling the bottom chambers to beat. So in order to keep the bottom chambers beating steadily and from preventing them from going too slow after burning the bridge, we have to put in some type of pacemaker, because something has to direct the bottom pumping chambers to keep beating. And whether we use a standard pacemaker or a leadless pacemaker, which I've reviewed in my pacemaker video, that pacemaker, while the top chambers are in atrial fibrillation and no signals are getting down from top to bottom, that pacemaker will continue sending regular pulses to the heart that the person doesn't feel. And we can set it at 60 or 70 or 80 or 50. And the pacemaker has a sensor in it so it knows when the person is doing activity, so it can speed up during physical activity, and it can slow down to its slowest rate that we can program, and we can change it at any time in order to keep the heart beating in a steady pattern. And for some people, doing an AV node ablation and putting in a pacemaker can be the treatment option that finally gets their symptoms under good control. I mentioned earlier a term called atrial flutter, and that reminds me that I wanted to talk about different types of fast rhythms that can occur in the top part of the heart, because often people with atrial fibrillation have more than one type of rhythm, and they're all kind of related to each other, and we as physicians think about these different rhythms in our treatment strategy for each individual patient. We talked about how atrial fibrillation is this irregular chaos, this shivery, irregular seizure-like pattern that you're now familiar with. Atrial flutter is a simpler rhythm, which is a large short circuit that can go round and round and round the top left chamber of the heart, or the top right chamber of the heart, the right atrium, which is actually more common. And sometimes people who have atrial fibrillation will sometimes also have atrial flutter. A third fast rhythm in the top chambers is called atrial tachycardia, and that could be one of those trigger spots that just fires over and over again. Atrial fibrillation, as I said, can create an irregular pattern in the bottom chambers, and heart monitors are really good at detecting that irregularity and diagnosing A.Fib. But sometimes people can have fast rhythms that are atrial flutter or atrial tachycardia that can create a very regular fast pulse, and sometimes heart monitors like watches and smart apps on the phone are not quite as good at picking those out because the pulse may be fast but in a very regular pattern, and those types of monitors may not be able to tell that the person's in an abnormal rhythm versus simply exercising and having a normal, regular, fast heartbeat. And the reason I mention all of these is because they are related, and people with A.Fib will often have more than one, and so the choice of medications or the pattern of ablation that we may perform will take into account the various rhythms that we have seen in a particular person. Sometimes people may have an atrial tachycardia that may trigger an episode of atrial fibrillation. Sometimes an episode of atrial fibrillation will slow down and simplify to atrial flutter. And sometimes atrial flutter will go back into atrial fibrillation. When I say slow down, by the way, I'm referring to the top chambers. Atrial fibrillation in the top goes at 400 or 500 beats a minute. Atrial flutter is often between 200 and 300 beats per minute in the top chambers. And of course, those are both different from what's going on in the bottom chambers, which is determined by how many signals get across that bridge. With atrial flutter, if the top chambers are going at 300 times a minute and every other signal gets down that bridge to the bottom, then the pulse can be 150, where there's a 2-to-1 relationship between the top and the bottom. That's a very common pattern that we'll see in patients who have atrial flutter at times. So in summary, if somebody has atrial fibrillation, there are 3 main steps that we will follow. And just to review it one last time, step 1 is to reduce the risk of stroke, almost always with a blood thinner medication. Sometimes, if they can't tolerate a blood thinner, a person will have a procedure to block off that left atrial appendage as a substitute, but a blood thinner is our best option. Step 2, keep the heart slow during atrial fibrillation by using medications to slow down that bridge between top and bottom. And in many people, we will proceed to step 3, where we try to keep the heart in normal rhythm by doing various things, including cardioversion or catheter ablation, or using antiarrhythmic medications to try to quiet down the trigger spots, deal with the scarred areas, and try to keep and retrain the heart to be in normal rhythm. Thank you so much for watching. I do hope that this video was helpful to help you understand what is atrial fibrillation and what are the steps of treating it. Talk to your doctor about your specific situation, but now you can go into that conversation well educated, and you can ask good questions so that you can feel comfortable with the strategy that you're creating together to manage your atrial fibrillation.